Bismillahirrahmanirrahim. So now we are going to continue the fifth session of our 100-point series. So here we are going to talk about the renal or the Garrota fascia. Enclosing the perinephric fat is a membranous condensation of the extraperitoneal fascia, that is the renal fascia. That is also called as Garrota fascia. Here you can see in the picture the point 3, I guess. So this thing over here, okay, I guess it is prominent. Let's say it is prominent. But let me change the color. We'll go with blue. So this fascia, like over here, which is enclosing the subcutaneous fat, that is not subcutaneous fat, but that is enclosing the fat. So enclosing the perinephric fat. So the fat that is enclosing the kidney, that is surrounding the kidney, that is called as the perinephric fat, is a membranous condensation of the extraperitoneal fascia, the renal fascia. The suprarenal gland, which is shown in the picture 4, like over here. So this is the suprarenal gland. They are enclosed in this fascia compartment. In this facial compartment, usually separated from kidney by a thin septum. So there is a thin septum. I guess that is not evident in this picture. So there is a thin septum that is separating the suprarenal gland from the kidney, and that is also enclosed in this facial layer. But remember that the suprarenal glands and the kidneys are separate from each other, and that thin membrane is separating these two structures. Note, the renal fascia must be incised in any surgical approach to this organ. So if we have to do any surgical approach to the kidneys, so we definitely have to remove the renal fascia first. Then we'll talk about the perinephric abscess. So here you can see there is a perinephric abscess in this area. What is that called? I don't know. I guess that is the dark area. Okay. So most infections of the perinephric space occur as a result of extension of an ascending urinary tract infection, commonly associated with the nephrolithiasis or the tuberculosis. The perinephric abscess typically descends down between the two sheets of the renal fascia along the psoas major muscle. Okay. In case of abscess located behind the psoas major muscle, it descends down and may affect the hip joint. Okay, so in case the abscess located behind the psoas major muscle, it descends down and may affect the hip joint. If the abscess spreads up, it will reach the diaphragm and irritate the phrenic nerve. As a result, the patient will feel a pain in the right shoulder. I have to read that once again. In the case of an abscess located behind the psoas major muscle, it descends down and may affect the hip joint. And the abscess spreads up, it will reach the diaphragm and irritate the phrenic nerve. As a result, the patient will feel pain in the shoulder joint. Nephrolithiasis, Staghorn calculi. So here you can see in the X-ray picture there are Staghorn calculi, and if we do the biopsy and the removed kidney, you can see the Staghorn calculi is covering all of this structure, like a big horn, like the horns of a stag. Okay, so renal calculi are solid concretions, crystal aggregation formed in the kidney from the dissolved urinary minerals. If stones grow to sufficient size before passage, at least 2 to 3 millimeters, they can cause obstruction of the ureter or cause the renal colic, that is pain in the ureter. The renal stone can develop in the renal pelvis and greater calyces, and in advanced cases has a branching configuration which resembles the antlers of a stag. Staghorn calculi are composed of magnesium ammonium phosphate, which form in the urine that has a normally high pH, that is alkaline pH above 7.2. Normally the urine pH is like 5.5 or something close to 5.5. This high pH usually develops because of recurrent urinary tract infection with microorganisms such as Proteus mirabilis. You know that Proteus mirabilis contains ammonia, so it is urease positive. So urease positive organisms can convert the urea into ammonia. So when they can produce ammonia, so that ammonia being an alkaline agent, so that causes alkalinity or the high pH in the calyces, and that high pH will lead to the formation of magnesium ammonium phosphate stones. Then we have horseshoe kidney, the pelvic kidney. This is something that I was talking about previously when I was trying to confuse you on the inferior mesenteric artery and the superior mesenteric artery. So now we'll talk about it over here. So horseshoe kidney is usually normal renal function, predisposition to the calculi. So in a horseshoe kidney, although it is a congenital anomaly, the lower poles of the kidney are joined together, but the function of the kidney is usually normal and the patients are totally asymptomatic. But there is a predisposition to develop the calculi. Is a fusion of the both kidneys at their end and failure of the fused kidneys to ascend. Why the fused kidney won't be ascending? Because the inferior mesenteric artery that is lying at the level of L3, they will be obstructing the ascent of the kidney. So is fusion of both kidneys at their end and failure of the fused kidney to ascend. The horseshoe kidney hooks under the origin of inferior mesenteric artery. The pelvic kidney is caused by a failure of the kidney to ascend. So here is the pelvic kidney, that is normally the kidneys are formed in the intrauterine life. The kidneys are formed in the pelvis and then they ascend from there to the level that is L2 level. So if the kidneys are not ascending upwards, that is called as a pelvic kidney, and we must take a good care of pelvic kidney whenever we are doing like procedure in the pelvic cavity. because there is a chance of damaging that kidney. Moving forward, we'll talk about the 50th point, that is ureters. So there are three constriction of ureters. We saw about three constriction of esophagus before that, and now we are talking about three constrictions of ureter. The three constriction of esophagus is for reviving purposes. That was one where the pharynx was conjoining with the esophagus, or pharyngoesophageal. That was at the pharyngoesophageal junction, the first one. The second one was where there was at the level of T4, basically where the trachea and where the trachea at the level of T4, where the trachea was passing interior, where the trachea and the ascending aorta, or maybe the descending aorta, was passing anterior to the esophagus. The second constriction was at that level, and third constriction was at the level of esophageal hiatus in the diaphragm. So those were the three constrictions for that. And now we're talking about the three constriction of the ureter. Ureter, located on the anterior surface of the psoas major muscle, has three constriction. First constriction is at the pelvic ureter junction, that is at the level of L1. Second constriction lies at the level of pelvic brim, level of the sacroiliac joint, and the third constriction appears at the ureter, lies obliquely in the wall of the urinary bladder, level of the ischial spine. So what is pelvic ureter junction? Suppose there we have a kidney and it is a ureter, and before ureter there is something that we call pelvis, like the callus is joined together to form the renal pelvis. So at the junction of pelvis and ureter, that is called as the pelvic-ureteric junction. At that point there are minor constriction, and this constriction can be potential site of obstruction by the kidney stones as well. So this thing can happen over there. So first constriction is at this point, second constriction is at the pelvic brim, and third constriction is at the wall, at the point where the ureter is entering in the wall of urinary bladder in an oblique fashion. So third constriction is over there. So the first one over there, this is an autopsy finding. First one and second point is over there, and third point is over here. Then what are suprarenal glands? They are endocrine glands having cortex and medulla. The adrenal cortex secretes the corticosteroids, aldosterone, hydrocortisone, and the genital hormones. So there are layers like GFR layers, the granulosa, fasciculata, and reticularis, and there are some hormones associated with that which I don't remember right now. I guess the granulosa was secreting aldosterone, then fasciculata was releasing cortisol, and the reticularis was releasing androgens. Let's see that. The hormones of adrenal cortex. So aldosterone, that is coming from the zona granulosa most probably. Yep, zona granulosa is producing aldosterone, that is the mineralocorticoid. Zona fasciculata is giving the corticosteroids, and the zona reticularis is giving the androgen, and there is some overlapping between them as well. So moving back to our PDF, here we are talking about the adrenal. The cortex is producing these hormones, and then there is medulla, and medulla is producing epinephrine and norepinephrine. The chromaffin cells of the adrenal medulla, so the chromaffin cell of the adrenal medulla secrete two catecholamines, epinephrine and norepinephrine, which affect the smooth muscles, the cardiac muscle, and the gland in the same way as the sympathetic stimulation, because in the sympathetic stimulation there is excessive norepinephrine in the synaptic clefts, and in the case of the catecholamines, which are epinephrine and norepinephrine, both of them function in somewhat similar fashion, and resultantly there will be a sympathomimetic effect of these these two catecholamines being secreted into the circulation. So the pale portion is the cortex, while the inner red portion is the medulla in this picture. Sympathetic stimulation or hypersecretion of the catecholamines, tumor of the adrenal medulla or sympathetic chain ganglia, result in the episode of tachycardia, sweating, and high blood pressure. There are two conditions in which we see that. First one is pheochromocytoma, and the second one is neuroblastoma. Pheochromocytoma is more prevalent among adults if they have the condition, and neuroblastoma is seen in the pediatric population, that is in the children. Unpaired tributaries of inferior vena cava. The right renal vein is much shorter than the left. Both veins lie anterior to the corresponding artery in the hilum of the kidney. So in the hilum we find vein anterior to the artery. The right renal artery is shorter than the left one. The long left renal vein is joined by the left suprarenal and the left gonadal artery. So the left suprarenal from here and the left gonadal artery coming from the testes or ovaries, that joins the left renal vein, and then all these three veins, they will have a long course to drain into the inferior vena cava. Testicular vein before it reaches the inferior vena cava. The right suprarenal vein and the right gonadal vein drain directly into the inferior vena cava. Unpaired inferior vena cava tributaries. The right suprarenal and the right gonadal vein, they are unpaired because from this side the right suprarenal vein and the right gonadal vein, they are not paired in a sense that there is no counterpart left gonadal vein or the left suprarenal vein which is draining directly to the inferior vena cava. So that is why they are termed as unpaired tributaries of the inferior vena cava. Then what is varicocele? Varicocele, it is the enlargement of the pampiniform plexus that produces worm-like scrotal mass and enlargement of the spermaticone. Varicocele may be the reason of low sperm count. So you must remember here we have the worm-like, or it is also, in the question stand that sometimes they write bag of worm appearance, or on palpation we can find a bag of worm structure in the scrotum. So that bag of worm is basically the pampiniform plexus that has been dilated. The varicocele formation usually on the left side and may disappear in the supine position of the body. Varicocele may indicate kidney disease or may signal a retroperitoneal malignancy obstructing the testicular vein. Why a kidney disease? Because we have just seen that the left gonadal vein is draining into the left renal vein. So if there is any kidney disease which is obstructing the flow through the left renal vein, or there is any structure which is obstructing the flow through the left renal vein, all these things can cause the pooling of the blood in the left gonadal vein or the left renal vein, and ultimately that will lead to the varicocele, as you can see in this picture. Moving to the pampiniform plexus, each testicular or ovarian vein is formed by the coalescence of the pampiniform plexus, the testicular and the deep inguinal ring. So the testicular at the deep inguinal ring, the ovarian at the margin of superior aperture of the pelvis. So this is the pampiniform plexus. Each testicular and ovarian vein is formed by the coalescence of the pampiniform plexus. The testicular vein is formed at the deep inguinal ring, while the ovarian vein is formed at the margin of the superior aperture of the pelvis by the coalescence of the pampiniform plexus. The veins run accompanied by the corresponding arteries. The left pampiniform plexus enters the left renal vein. The right one enters directly into the inferior vena cava, inferior to the left to the right renal vein. Okay, there is why the varicosity and engorgement of the pampiniform plexus that produces the scrotal mass is more often located on the left side. Then we have hydrocele. So here you can see hydrocele. So the tunica vaginalis testis or the remnant of the processes. So the tunica vaginalis testis or the remnant of the processus vaginalis of the peritoneum may form a hydrocele. Here you can see a picture of that as well. So in the normal adult males, there is a structure that we call the tunica vaginalis. The tunica vaginalis is the remnant of the processus vaginalis. Processus vaginalis is the structure that directs the testis descent from the abdominal cavity all the way down to the scrotum. Now in the adults, that cavity, that processus vaginalis has been obliterated, and that thing is now supporting the testis into the scrotum. If that remains patent, so that can cause the peritoneal fluid to enter the scrotum, and that will result in the hydrocele. Or in another condition, if the epithelium of that tunica vaginalis, I guess where is tunica vaginalis? Okay, so this is the epithelium of the tunica vaginalis. It starts producing excessive amount of fluid due to some reason, so there will be hydrocele. Okay, hydrocele in the spermaticode is smooth, sausage-like structure that persists under the compression and does not disappear in the supine position. We saw previously that the varicocele was disappearing in the supine position. Where was that? Enter the renal cava and ovarian margin. Okay, pardon me. Where is that? Left side. Yeah, that disappears in the supine position of the body, while the hydrocele will not disappear on the supine position in the scrotum. And we are talking about the hydrocele of spermaticode, right? So this is spermaticode, and hydrocele can develop in the spermaticode as well. In the scrotum, communicating hydrocephalus with a transillumination, it produces a reddish glow. Okay, whereas light will not penetrate other scrotal masses such as hematocele or solid tumor, or not even varicocele or herniated bowel. Testis is pressed by the tunica vaginalis against the internal spermatic fascia. So here you can see when we glow a light, so the hydrocele will glow red, but other structures will not glow like that. Moving forward to point number 54, we are talking about hemorrhoids. So hemorrhoids are the masses that typically protrude from the anus during the defecation. External hemorrhoids are dilated tributaries of the inferior rectal vein. Inferior rectal vein, like over here you can see these are external hemorrhoids, and they are the tributaries of the inferior rectal veins below the pectinate line, and are painful because the mucosa is supplied by the somatic afferent fibers of the inferior rectal vein from the pudendal veins, right? Painful because the mucosa is supplied by the somatic afferent fibers from the inferior rectal nerves. I'm sorry, not veins. Inferior rectal nerves from the pudendal nerves. So below the pectinate line, the nerve supply is coming from the inferior rectal nerves, and they're coming from the pudendal nerves. So the below the pectinate line, they are painful. Okay, so external hemorrhoids are painful. Okay, because the mucosa is supplied by the somatic afferent fibers of the inferior rectal nerves. Okay, so they can be painful. The internal hemorrhoids are dilated tributaries of the superior rectal veins above the pectinate line and are not painful. So the internal hemorrhoids are not painful, while the external hemorrhoids are painful because The mucosa is supplied by the visceral afferent fiber. It frequently develops the chronic alcoholics because of liver cirrhosis and portal hypertension syndrome. So the external hemorrhoids are painful while the internal hemorrhoids are not painful. Then point number 55 is about perineal pouches or the deep perineal pouch. So let's look at that. So there are the deep perineal pouch. The deep perineal pouch is formed by the fascia and the muscles of the urogenital diaphragm. It contains sphincter urethrae muscle, the deep transverse perineal muscle, and the bulbourethral or Cowper's gland in the males only. Ducts perforate perineal membrane to enter the bulbar urethra. So number one is the sphincter urethrae muscle. Where is sphincter urethrae muscle? I guess this one is it. Sphincter urethrae. The sphincter urethrae. I guess this is internal sphincter. So this is sphincter urethrae maybe. So sphincter urethrae muscle, then transverse perineal muscle. The transverse perineal muscle. Okay, there is a transverse perineal muscle. I don't know what that is. So there is a transverse perineal muscle, and then we have bulbourethral glands. So these are the bulbourethral glands. These two, they're found in the males only. And the ducts perforate the perineal membrane. They are perforating the perineal membrane to move downwards and enter the bulbar urethra. So the ducts will perforate the perineal membrane to enter the bulbar urethra from the bulbourethral gland of Cowper that is found only in the males. Remember that. Now we'll see these structures from here and then we'll move in that direction. Firstly, this is the bladder wall, this one. Then the urethral crest is over there, over inside the, from coming out of the bladder. Then seminal colliculus. This structure is the seminal colliculus and it has ejaculatory duct orifices. Then we have prostatic utricle over there. Like I guess this is the prostatic ureticle. Then deep perineal pouch, then superior fascia is over there. Then urogenital diaphragm, perineal membrane, inferior fascia, bulb of the penis. So this is the bulb of the penis. Then we have prostatic sinuses. These are the prostatic sinuses which are entering the urethra from the prostate gland. Then prostate gland is surrounding this one. Then ejaculatory duct orifices are over there, prostatic duct orifices, and bulbourethral glands and duct of the bulbourethral gland. Then we have superficial perineal pouch. This was the thing. These were the contents of the deep perineal pouch. Number one, sphincter urethrae muscle. Number two, deep transverse perineal muscle. And number three, that is bulbourethral gland that is found in the males only. Talking about the superficial perineal pouch, we'll find ischio-cavernous muscle. Number one, this is the ischio-cavernous muscle. Ischio-cavernous muscle related to the crus of penis in the males and crus of clitoris in the females. Okay, that is ischio-cavernous muscle. Then we have bulbospongiosus muscle that is related to the bulb of the vestibule in the females and bulb of penis in the males. The bulbospongiosus is number two. So number one is the ischio-cavernous. Then number two, this is the bulbospongiosus found in both males and females. And number three, superficial transverse perineal muscle related to the perineal body, and that is found in both genders. So this is perineal body over here, and here we have perineal body again. It is basically confluence of a lot of muscles. So the number three is the superficial transverse perineal muscle. So these three muscles are found in the superficial pouch. That are ischio-cavernous muscle, the bulbospongiosus muscle, and the superficial transverse perineal muscle. Moving forward, we have urinary leaks. They are very high yield. They ask you a lot of times on the step exams about the urinary leak and locations of the accumulation of the urine. So after crushing, blow or penetrating injury, the spongy urethra is the one which is found in the corpus spongiosum inside the penis. So the spongy urethra commonly ruptures within the bulb of penis and urine leaks into the superficial perineal pouch. So superficial perineal pouch like this one, which includes the ischio-cavernous muscle, the bulbospongiosus muscle, and the superficial transverse perineal muscle, the urine will start leaking into that area. So here you can see, I guess it is coming into this zone, like this is the superficial perineal pouch maybe. The superficial perineal fascia keeps the urine from passing into the thigh or the anal triangle, but after distending the scrotum and penis, the urine can pass over the pubis into the anterior abdominal wall deep to the deep layer of superficial abdominal fascia. Okay, it was like very phonetically pleasing to speak deep to the deep layer, but I couldn't understand any word out of that. The superficial perineal fascia keeps the urine from passing into the thigh or the anal triangle, got it, but after distending the scrotum, now if the scrotum is distended like this, urine can pass over the pubis into the anterior abdominal wall deep to the deep layer of superficial abdominal fascia. So read it once or twice and then you will understand the concept. Maybe I will be able to understand the concept later on. Then ischiorectal abscess, what is that? This is the site of formation of ischiorectal abscess. So ischiorectal abscess is an important surgical condition which usually results from spread of infection through the external sphincter ani into the ischiorectal fossa. So ischiorectal abscess is found in the ischiorectal fossa, right? and that is due to the spread of infection through the external sphincter ani into the ischiorectal fossa. So this thing is ischiorectal fossa, and if there is infection spread through the external sphincter ani into the ischiorectal fossa, so we will be finding ischiorectal abscess over there. Ischiorectal abscess is a surgical emergency which should be immediately drained by a wide cruciate incision through the skin of the base of fossa to avoid fistula formation. Because if this abscess is not removed, there will be formation of the fistula. A surgeon should avoid the lateral wall of the ischiorectal fossa because here located pudendal Alcock's canal and the pudendal nerve and the internal pudendal artery. Because here is located the pudendal Alcock's canal over here. I can't see anything, but there is something that we call the Alcock's canal with the pudendal nerve and the internal pudendal artery. So inside the Alcock's canal we have pudendal nerve and the internal pudendal artery on the lateral wall of this ischiorectal fossa. So while draining this abscess, we must take good care of the Alcock's canal. Point number 57 is about urinary bladder cystoscele. So when we were talking about the leakage of the urine, so we just talked about the rupture of the spongy urethra. But there is another point where urethra can be damaged, and there is a membranous urethra over here. No, there is no membranous. Membranous urethra is over here. So if the damage of the urethra takes place in this direction, so the urine will start leaking from here, and that will fill the pelvis, and the prostate will be high riding. So remember these things as well. And let's move on. So urinary bladder cystoscele means herniation of the bladder. Okay. So loss of the bladder support in the females by damage to the pelvic floor, levator, and eye muscle during the childbirth, for example, laceration of the perianal muscles or lesion of the nerve supply. It can result in protrusion of the bladder into the anterior vaginal wall and the loss of urine when a woman stains and coughs. So here you can see that the bladder is herniating into the anterior vaginal wall and depressing that, or maybe compressing that. So it can result protrusion of the bladder into the anterior vaginal wall and loss of the urine when a woman stains or coughs. The cystoscele will result in what type of incontinence? That is stress incontinence. Yep. So here you can see there we have the uterus, and then the urinary bladder is like over here, and the urethra is present here, and cystoscele means the bladder is protruding into the anterior vaginal wall, anterior wall of the vagina that is externalized. Okay, it can come out as well. Then vagina, rectum, and here we have the rectouterine pouch. Moving forward to the patent urachus. A patent urachus, distal portion of allantois. The distal portion of allantois is called as the patent urachus. It is basically a connection between the urinary bladder and the umbilicus. So a patent urachus, distal portion of the allantois needs to be surgically removed. The main sign is the leakage of urine through the umbilicus. There are three main anatomical causes. First one is urachal fistula. There is free communication between the bladder and the umbilicus. So the fistula is very dangerous. Like the bladder and the umbilicus are freely connected. There is a patent tube, and the urine can flow from here outside from the umbilicus. Urachal cyst. There is no connection between the bladder and the umbilicus. Okay, so there is no connection between bladder and umbilicus, but there is a cyst formation somewhere between the urachal urethra was not completely obstructed, and somewhere there was a patency, and in that there was later on infection developed or some fluid was accumulated, and then that resulted in the formation of urachal cyst. What is urachal sinus? Pardon me. Urachal sinus is the pouch opens towards the umbilicus. Like distally it is closed, but proximally towards the umbilicus it is patent, so it is called as sinus. It is not a fistula because it is not a connection between two cavities or two areas. It is not a connection between two things. It is just a sinus. That is, you may say that this is a very deep umbilicus. You should not say that, but I'm just trying to tell you that it is obstructed over here. It is closed, but not completely closed. So that is why there is a patency close to the umbilicus. Then moving forward, we have paracentesis of the urinary bladder. How do we do that? We do suprapubic aspiration, paracentesis of the urinary bladder. Urine can be removed from the bladder without penetrating the peritoneum by inserting a needle just above the pubic symphysis when the bladder is completely distended. Because when the bladder is completely distended, it moves above the pubic symphysis. Okay, the needle passes successfully through the skin, superficial and the deep layer of superficial fascia, linea alba, transversalis fascia, extraperitoneal connective tissue, and the wall of bladder. So these are the layers that are being pierced. That is the upper one, skin, and then superficial and deep layers of superficial fascia, and the linea alba, transversalis fascia, extraperitoneal connective tissue, and the wall of the bladder. Point number 58 is about the urogenital system development. So let's see that. In the adult female, there will be ovaries, uterine tube, uterus, cervix, and upper part of the vagina. Okay, so pardon me, it must not be started from there. So this is the main reference point, and then we'll go to the females and the males. So in the embryo, they are just gonads. They develop to form ovaries in the females and testes in the males. The paramesonephric ducts or the Mullerian ducts. So I just when I was recording the series of the repro unit, so I made a self-made mnemonic that write it females like that with the ph. So if you write female with the ph, so this will help you remember that the paramesonephric ducts are going to be patent in the females, and they will be forming uterine tubes in the uterus and the cervix, upper part of the vagina and stuff like that, and it will be absent in males, right? While the mesonephric duct that is present, that is starting with the M, so that is present in the males, and that is also called as Wolffian duct, and that is going to form epididymis and ductus deferens, seminal vesicle, ejaculatory duct. So it is easy to remember both of these things. Like this is Mullerian duct, and if you turn the M upside down, so you have Wolffian duct, W. And paramesonephric duct can be remembered with the females with the PH, and best of luck with the Mullerian because there is no mnemonic I have for this one. If you can remember it, then best of luck. Then we have clitoris that is coming from the phallus. So there is in the embryo we have phallus that makes clitoris in the females and glans and body of the penis in the males. Then urogenital folds that are going to form labia minora in the females, while ventral aspect of the penis in the males, and labioscrotal swellings which is going to form the labia majora in the females, while scrotum in the males. Moving forward to the hypospadias and the epispadias. So hypospadias occurs when the urethral folds, these are urogenital folds by the way, ventral yeah. So we are talking about these ones. So when the urethral folds fail to fuse completely, resulting in the external urethral orifice opening onto the ventral surface of the penis. Ventral means suppose there is a penis over here, like erect penis. So the ventral surface is the surface below, and this one is the dorsal surface. So if there is an opening on the ventral surface, it does not look like that. It is just an opening. It is not like something hanging down. It's just an opening over here. So if there is an opening, that is called as hypospadias. It is generally associated with a poorly developed penis that curves ventrally, known as chordee. Okay. Then we have epispadias, occurs when the external urethral orifice opens onto the dorsal surface of the penis. It is generally associated with extrophy of the bladder as well. So extrophy of the bladder means the bladder is present outside the body. That is extrophy of the bladder, and that is also associated with the epispadias. Point number 59 is about prostate tumors and the prostate cancer. So here is the prostate gland, and there is like a lot of malignancy going on with that. So it is usually it really begins in the posterior lobe. Now we are talking about prostate cancer. This is not benign prostatic hyperplasia or stuff like that. We are talking about prostate cancer, full-blown prostate cancer. So it usually begins in the posterior lobe of the gland, and early stages are often asymptomatic and may be found during the digital rectal examination. But remember that it is a benign prostatic hyperplasia which is going to cause the urinary symptoms of frequency and urgency and hesitancy, blah blah blah. So those symptoms are caused by the benign prostatic hyperplasia, which is involving the middle or the lateral lobes. But the cancer that is involving the posterior lobes, it is way behind the urethra, so it is not going to cause urinary symptoms, and that is a bad sign. Because if there are urinary symptoms, if there would be urinary symptoms which are not present in the case of cancer, it would have been detected early on. And now when there are no symptoms, so it cannot be detected until late, and it may be, by the time of diagnosis the cancer may have metastasized. So prostatic malignancies tend to metastasize to vertebrae and brain because prostatic venous plexus has numerous connections with the vertebral venous plexus via sacral veins, and the thing to remember is that these vertebral venous connections are valveless. That is, they can move in both directions from the brain to the vertebral column and vice versa. So whenever there is connection between the prostatic venous plexus and the vertebral venous plexus, so the metastasis originating from the prostate can metastasize to the vertebral veins and go all the way to the brain. That is why the prostatic cancer is very commonly metastasizing to the vertebral column and the brain. What is benign prostatic hyperplasia? Benign hypertrophy of the prostate. So BPH is common in men after middle ages. It is very common. Prostate adenoma, benign hypertrophy usually involves the median lobe. Benign hypertrophic prostate or benign prostatic hyperplasia is a common cause of urethral obstruction leading to nocturia, need to void during the night, dysuria, difficulty and or pain during the urination, and urgency, sudden desire to void. The prostate is examined for the enlargement and the tumors by digital rectal examination. So here you can see the prostate over there that is enlarged and the urethra is being compressed between that. Yeah. So moving forward to prostatectomy, how do we do this? So a prostatectomy may be performed through a suprapubic or the perineal incision of the transurethral. So the transurethral procedure is called as TURP, transurethral resection of the prostate. but it can also be done suprapubic or perianal. So the number one is suprapubic, we make an incision over there. The perineal one is we make incision over there, and the transurethral is that we go through the urethra and then we dissect the prostate and we bring it out like from the same path. Because the damage to the nerve in the capsule of the prostate around the urethra, cavernous sinus can cause impotency or erectile dysfunction and or urinary. Because of the damage to nerves, so if the nerves are being damaged in the capsule of the prostate around the urethra, cavernous nerves, they can cause impotency, that is erectile dysfunction and or urinary incontinence. Pelvic splanchnic nerves may be injured in the case of intensive dissection of the pelvic lymph nodes, prostatic cancerectomy, and as a result, autonomic innervation of autonomic innervation of the derivative of hindgut may be affected. So the pelvic splanchnic nerves may be injured in the case of intensive dissection of the pelvic lymph nodes. Because of some reason, not because of benign prostatic hyperplasia, because there is no metastatic potential with the BPH. But if we are doing some kind of pelvic lymph node dissection, so the pelvic splanchnic nerves can be damaged. Prostatic cancerectomy. So when we are doing the prostatic cancerectomy, in that case we need to do pelvic lymph node dissection as well, and as a result, autonomic innervation of the derivative of the hindgut may be affected. Now let's talk about male urethra. There are like 4 parts to that. Number one is prostatic part. So they did not start with the there is membranous part and then spongy part. There was another part, like I don't know, the first part was like intravesicular part maybe, but the part that was pre-prostatic part, it also had a name, so they have not given it a name, so we'll about that. So prostatic part is the widest part and most dilatable part. Opening of the 2 ejaculated ducts are seen on each side of the seminal colliculus. Each side on the seminal colliculus, these are opening of the 2 ejaculated ducts from each side of the from each testis. From testis on each side, there are 2 ejaculated ducts which are entering the prostatic urethra, and that is most dilatable part of urethra as well. What is membranous part? So membranous part is the part between the prostate and the corpus spongiosum. So membranous part is in the urogenital diaphragm, surrounded by the external sphincter. It is the shortest, narrowest part of the urethra in the males. Bulbourethral gland lies posterolateral to this part inside the urogenital diaphragm, deep perineal pouch. So we have seen that this is in the urogenital diaphragm, surrounded by the external sphincter. So this part is present, like we have to go up, over here. So here you can see that we have the membranous part. I guess this is because this is the prostatic part, and then here we have the membranous part that is present in the urogenital diaphragm, and both urethral glands are located posterolateral to that. Posterolateral to this one. So they are located posterolateral to this part inside the urogenital diaphragm. Spongy or penile part is the longest, passes through the bulb and the corpus spongiosum of the penis. There are 2 dilations, the bulbar fossa in the beginning. So there will be a dilation in the bulbar fossa in the beginning, I guess over here maybe, and then in the navicular fossa in the glans penis. So in the navicular fossa over here in the glans penis, there is a second dilation. First one is in the bulbar fossa, and second dilation is in the navicular fossa. The ducts of the bulbourethral glands open in the bulbar fossa. The ducts of the bulbourethral gland open into the bulbar fossa. Then we have 2 sphincter of urethra. First one is the internal and second one is the external. So internal urethral sphincter is present right over here, in the pre-prostatic part. The internal urethral sphincter is made of smooth muscle in the neck of the bladder and has sympathetic innervation, and it is involuntarily controlled. And whenever there is sympathetic surge in the fight and flight mode, the internal urethral sphincter is being closed, and that is a smooth muscle sphincter. Secondly, about the external urethral sphincter, has skeletal muscle fibers and surrounds the membranous part of the urethra, supplied by the perineal branch of the pudendal nerve. So external urethral sphincter has skeletal muscle fibers which is present over here, like post-prostatic. So pre-prostatic we have internal urethral sphincter, and post-prostatic we have external urethral sphincter. It has skeletal muscle fibers and surrounds the membranous part of the urethra, and it is supplied by the perineal branch of the pudendal nerve. I guess it is the diaphragm. What was the name of the diaphragm? This one. It is a urogenital diaphragm which contains the skeletal muscles which are providing the external urethral sphincter. Moving down. Now we have over here that we're done. So it is supplied by the pudendal nerve, while the internal urethral sphincter was supplied by the sympathetic innervation. Now talking about the ejaculatory duct, it is very narrow duct, 2 centimeter long. The ejaculatory duct, where is the ejaculatory duct? Like this one? That is not ejaculatory duct. Okay, so that is ejaculatory duct. So it is like 2 centimeter long, formed by the union of ductus deferens and the seminal vesicle. So when the ductus deferens, which is coming from here, like this is the ductus deferens all the way, and the seminal vesicle, this is joined together to form this thing. Let me zoom it in. So this is the ejaculatory duct over here, like this thing. So it is formed due to the fusion of the ductus deferens, that is the blue one, and the seminal vesicle, that is this pink or purple one. So both of them fuse together to form this this thing that is called as ejaculatory duct. Okay, in sphere, it served to the passage of seminal fluid from the ductus deferens to the prostatic urethra. Okay, then moving forward to the pudendal nerve, S2 to S4. What do they do? So the principal somatic, motor and sensory nerve, so the principal somatic, that is motor and sensory nerve supplied to the perineum, is coming from the pudendal nerve. It lies against the ischial spine as it passes through the lesser sciatic foramen to the transverse pudendal canal on the lateral wall of ischio-rectal fossa. So it lies against the ischial spine as it passes through the lesser sciatic foramen to traverse the pudendal canal on the lateral wall of the ischio-rectal fossa. Branches: inferior rectal nerve. Number 1 is inferior rectal nerve. It supplies the external anal sphincter and muscle and skin around the anus. The perineal nerve. Deep branches is motor nerve to the muscle of urogenital triangle, and superficial branch gives cutaneous posterior scrotal labial branches. The number 3 is dorsal nerve of the penis or clitoris, supplies the body prepuce and glans of the penis or clitoris. So these are the 3 nerves. The number 1 is the inferior anal or inferior rectal nerve over here, like this one. So it is supplying the external anal sphincter, muscle and skin around the anus. The perineal nerve is over, the perineal nerve is perineal nerve. So perineal nerve, deep branches is the motor nerve to the muscle of urogenital triangle, and superficial branches, the posterior scrotal nerves, these ones. So these are the perineal nerves over here. So these are perineal nerves, deep and superficial. So these are the deep ones, and then we have the superficial ones. Then the dorsal nerve of the penis or clitoris supplies the body prepuce and the glans penis. So these are the dorsal nerve of penis, or maybe dorsal nerve of clitoris in the case of females. So remember these things. And let's move on to the pudendal nerve block. That is very high yield, because they ask you about this thing in the step 1 examination. So to relieve the pain for mother and to prepare for an episiotomy, a pudendal nerve block may be administered during the early labor. So although it may be used to abort the labor, but not completely, because the mothers who want to feel the contractions but not that much, and they want to be present in the early stages of their child, early moments of the child after birth, so they prefer the pudendal nerve block. So pudendal nerve block is administered like that, or maybe the fetal head is very long and we need to do the episiotomy. So in that particular case, we administer the pudendal nerve block. The nerve may be blocked in 2 ways: either by piercing the vaginal wall posterolaterally near the ischial spine, or percutaneously along the medial side of the ischial tuberosity. Okay, we have to reach the ischial tuberosity somehow, either by piercing the vaginal wall posterolaterally near the ischial spine, or percutaneously along the medial side of the ischial tuberosity. Note: pain from the uterine contraction is unaffected because pelvic visceral pain is carried by the afferent fibers accompanied by the autonomic nerve. So pain of the uterine contraction will be unaffected. So the pain from the, I guess, vaginal orifice, or if there is some incision, will be affected. So why do we do the pudendal nerve block then? Okay, so I don't remember that. But pain from the uterine contraction is unaffected because the pelvic visceral pain is carried by the afferent fibers accompanied by the autonomic nerve fibers. Point number 63, that is about supply of the pelvic viscera. So for the pelvic viscera, the arterial supply is coming from the internal iliac artery. The parasympathetic innervation, preganglionic fibers are coming from the sacral parasympathetic nerve, S2 to S4. That are pelvic splanchnic nerves. And the postganglionic fibers are definitely the terminal ganglion, which are present on the individual viscera. The sympathetic innervation, the preganglionic fibers are coming from the intermediolateral columns of T12 to L2, that are sacral splanchnic nerves. Postganglionic inferior hypogastric plexus. Sensory innervation, dorsal root ganglion, S2 to S4 with the pelvic splanchnic nerves, and referred pain is going to the groin. Now let's talk about micturition reflex. So micturition reflex is happening like 1 to 3 at 3 levels maybe. So facilitating the emptying parasympathetic fibers. So the the innovations or the factors which facilitate the emptying or which facilitate the maturation are: number one, parasympathetic fibers. The pelvic splanchnic nerves, the pelvic splanchnic nerves, okay, stimulate the detrusor muscle, that is contraction and involuntary relaxation of the internal sphincter. So there will be contraction and involuntary relaxation of the involuntary. Okay, so just give me a second. So we were talking that the parasympathetic fibers, the pelvic splanchnic nervous system, stimulate the detrusor muscle. So the detrusor muscle will be stimulated, and the contraction of the involuntary detrusor muscle contraction and involuntary relaxation of the internal sphincter. The internal sphincter will be relaxed. The second point is somatic motor fibers. The pudendal nerve causes voluntary relaxation of the external and okay. So somatic motor fibers. The pudendal nerve causes the voluntary relaxation of the external urethral sphincter as well. Okay. Okay. So there will be two factors which are facilitating this one. Like initially there will be parasympathetic nerve that will cause the detrusor contraction and the relaxation of the internal urethral sphincter, and the inhibition of the somatic nerve fibers which are coming from the pudendal nerve to the external urethral sphincter. They will be inhibited, leading to the relaxation of external urethral sphincter, inhibiting emptying. So the factors which inhibit the emptying or inhibit the maturation are sympathetic nerve fibers, the sacral splanchnic nervous system. Okay. So sympathetic fibers which are coming from the sacral spinal splanchnic nervous system, they inhibit the detrusor muscle and stimulate the internal sphincter. Okay, remember one thing as well. The pelvic splanchnic nervous system is parasympathetic, P for pelvic, P for parasympathetic, while the sacral splanchnic is sympathetic, S for sacral and S for sympathetic. Remember this thing as well. Moving forward to the erection and ejaculation. So afferent fibers, dorsal nerve of the penis and clitoris form, the afferent fibers to the dorsal nerve of the penis or clitoris from the pudendal nerve. Okay, so the afferent fibers from the dorsal nerve. So there is some dorsal nerve of the penis or clitoris. They are coming from the pudendal nerve, which is going to the dorsal root ganglion of S2 to S4. The efferent fibers come. We are talking about the parasympathetic nerve supply, right? Okay, so efferent fibers, the parasympathetic nerve supply will cause erection. So parasympathetic fibers from the pelvic splanchnic nerves dilate the arteries supplying the erectile bodies of the penis, allowing them to fill with the blood. Somatic motor fibers, S2 to S4 fibers from the pudendal nerve, cause the contraction of the ischio-cavernous and the bulbospongiosus muscle to press the root of the penis and relax the external urethral sphincter. Okay, ejaculation, that is mediated by the sympathetic fibers L1 to L2 from the inferior hypogastric plexus or sacral splanchnic nerves, cause the contraction of the smooth muscle of the epididymis, ductus deferens, seminal vesicle, and prostate. Sympathetic nerve fibers stimulate the internal urethral sphincter to prevent the semen from entering. So they stimulate the internal urethral sphincter to prevent the semen from entering the bladder or urine entering prostatic urethra. So we have to prevent both of these things. Point number 65 is about incontinence. So weakness of the puborectalis, part of the levator ani muscle, may result in the rectal incontinence. Okay, so if the puborectalis is not functioning properly, so there will be rectal incontinence. Weakness of the external sphincter urethrae muscle result in the muscle in the urogenital diaphragm may result in the urinary incontinence. So there are two types of incontinence, either rectal or urinary. So if there is problem with the puborectalis part of the levator ani, that will result in the rectal incontinence, while there is weakness of the external sphincter urethrae will result in the weakness of the muscle in the urogenital diaphragm, and that may result in the urinary incontinence. Moving forward to the cryptorchidism. So undescended testis, cryptorchidism, when the testis fail to descend into the scrotum, this normally occurs within 3 months after birth. The undescended testis may be found in the abdominal cavity or in the inguinal canal. If neglected, malignant transformation may occur in the undescended testis, because there is constant irritation to that testis in the abdominal cavity or in the inguinal canal, so that may result in the malignant transformation. Note, in case of cryptorchidism, spermatogenesis is arrested and the spermatogenic tissue is damaged, leading to the permanent sterility, and in the bilateral cases. So if they have bilateral undescended testis, that may lead to the arrest of the spermatogenesis. Point number 67, that is torsion of the spermatic cord. So spermatic cord is over there, and here you can see a torsion of the spermatic cord. So main component of the spermatic cord are as follows. Number 1, ductus deferens. Number 2, testicular artery, direct branch of the aorta. Number 3, pampiniform plexus to become the single testicular vein, that is right, which goes to the inferior vena cava, and left, which will go to the left renal vein. Torsion of the spermatic cord produces acute pain with swelling because of twisting of the testicular artery that can result in the testicular avascular necrosis. Repair requires a high scrotal incision to untwist the cord, and the testis is sutured into the scrotal septum to prevent the recurrence. So whenever there is torsion, suppose this is the testis, and here we have the artery, and here we have a vein. So whenever there will be torsion, since the veins are low pressure system and the arteries are high pressure system, so initially there will be obstruction of the vein. So now when the vein is obstructed, the blood cannot leave the testis, so the blood has started accumulating inside that. If the blood is not leaving the vein, so resultantly no blood is entering through the arteries as well. So when there is increased pressure in the arteries and when the blood is not leaking out and there is ischemia going on, so the arteries become leaky or the capillaries they become leaky, and resultantly there will be hemorrhagic necrosis inside the testis. In the long run, when the torsion is like chronic or not chronic per se, but if the torsion is very prolonged, so in that case the arterial system is also obstructed, and then there will be ischemic necrosis, and resultantly avascular necrosis will be seen. Okay, point number 68, that is about the lymphatic drainage of the male viscera. So that is very high here, because most of the time they will ask you about this one. The testes and epididymis are going to drain into the lumbar lymph nodes. Scrotum, that drains into superficial inguinal lymph nodes. Penis, the skin goes to superficial inguinal, like just like scrotum. Glans goes to deep inguinal, and body and root goes to internal iliac lymph nodes. Prostate gland and bladder, they also go to the internal iliac lymph nodes, and the anal canal above the pectinate line go to the internal iliac, while below the pectinate line they go to the superficial inguinal lymph nodes. Let's repeat that once again because it is very high yield. For the testes and epididymis, we have lumbar lymph nodes. For the scrotum, we have superficial inguinal lymph nodes. For the penis, skin will go to the superficial inguinal, same as testes. Glans will go to the deep inguinal lymph nodes. Body and roots will go to the internal iliac lymph nodes, just like prostate gland and the bladder, which also go to the internal iliac lymph node. And also, anal canal above the pectinate line goes to the internal iliac, while below the pectinate line it will be emptying into the superficial inguinal lymph node, just like the scrotum and the skin of the penis. So make some correlations, and then you will be able to remember these things. Moving forward to the point, lymphatic drainage from the female viscera. So from the female viscera, the ovary and the uterine tubes to the lumbar lymph node, it is not very hard to remember because they are close to that. But the testes, you know that they have been descended from the abdomen into the scrotum, so it sometimes is confusing that why the lymphatic drainage of the testes all the way up into the para-aortic lymph node, but because the origin is from that side, that is why the lymphatic drainage is over there. Uterus, the lateral angle and teres ligament to the superficial inguinal lymph nodes. Fundus and upper part of the body to the lumbar lymph nodes. Lower part of the body to the external iliac lymph nodes. Cervix, external and internal iliac. Vagina, that goes to vagina superior to hymen to the external iliac lymph nodes, inferior to the hymen to superior inguinal lymph nodes. All the external genitalia with the exception of glans, clitoris, superficial inguinal lymph nodes. Glans and clitoris will go to the deep inguinal lymph nodes. So remember these things as well. Let's revise them once again. Ovary and the uterine tube go to the lumbar lymph nodes. The uterus, that drains to the lateral angle and teres ligament, superficial inguinal lymph nodes. Fundus and upper part of the body, lumbar lymph nodes. Lower part of the body, external iliac lymph nodes. Cervix will go to the external and internal iliac. Vagina, superior to hymen, will go to the external and internal iliac lymph nodes. Inferior to the hymen to superficial inguinal lymph nodes. All external genitalia with the exception of glans, clitoris, superficial inguinal lymph nodes, and the glans, clitoris will go to deep inguinal lymph nodes. And point number 69, that is about the arterial supply to uterus and the concept of hysterectomy, that is removal of the uterus. So the uterus is almost exclusively supplied by the uterine arteries from internal iliac artery. Uterine artery crosses the pelvic floor in the cardinal ligament. Ureter passes posterior to the inferior to the uterine artery. So remember, I don't remember that how many times I have reiterated that in different sections, so I will say that once again, that ureter is passing under all of the structure of the female urinary tract. The only structure which lies under the ureter is the common iliac artery. So the ureter is passing only above the common iliac arteries and under all of the rest of the structures, be it your ovarian artery or the uterine artery or the round ligament or even the Vas deferens for the case of males. So it is under most of the structures. The only structure which it lies above is the common iliac artery. Yep. Ascending branch of the uterine artery comes along the lateral wall of the uterus within the Brown ligament. So the uterine cardinal ligament, that is represented in picture 2, if you can see anything over there. Then the uterine arteries, which are represented in the picture number 1, so they are the exclusive blood supply to the uterus, and then the ureter passes posterior. So picture number 3, this is the ureter, and you can see it is passing behind this artery, that is the uterine artery. And point number 4, that is ascending branch of the uterine artery comes along the lateral wall of the uterus within the broad ligament. Note, during hysterectomy, ureter is in the greatest risk because of close relationship with the uterine artery and cervix of the uterus. It can either become deprived of its blood supply, or that can also be ligated, or that may be damaged or cut, ligated, but not. Because of its close relationship, we always have to protect the ureter. What is the concept of hysterectomy? So hysterectomy is a surgical removing of the uterus and may include removing of the cervix total and vagina, that is radical. So the total hysterectomy includes the removal of, the total hysterectomy includes the removal of the uterus including the cervix, that is total, and if you also include the vagina, that is radical. Blood supply to the ovaries is saved in case of partial hysterectomy. Ovarian suspensory ligament should be left intact because contain the ovarian artery, direct branch of the abdominal aorta and veins. In case of total hysterectomy with the cervix, pelvic splanchnic nerves may be affected that result in a bladder dysfunction because of the detrusor urine muscle loose parasympathetic innervation. That result in the bladder dysfunction because of the detrusor urine muscle loose parasympathetic innervation. Then we have point number 70, that is about part of the uterine tube. So I guess we should do it at least till 200, page number 200. So we'll do that. So what are the parts of the uterine tube? So the uterine tube pierces the uterine wall to open into the uterine cavity. The first part, so this is the uterine part. Uterine part is also called as the infundibular part. So this is the uterine part that pierces uterine wall to open into the uterine cavity. We are moving in this direction over here. So this is the uterine part, first part. Then we have isthmus, that is neck, the narrowest part of the tube just lateral to the uterus. Then we have ampulla, the most common site of fertilization as well as ectopic pregnancy. So ampulla, medial continuation of the infundibulum comprising of half of the uterine tube, usual site of fertilization. Then we'll talk about infundibulum, like this part over here. So funnel shaped expansion of the lateral end fringed with fimbriae, so it is fringed with these finger-like projections, overlies the ovary and receives the oocyte at ovulation. So it overlies the ovary is just like over here. So the infundibulum along with the fimbriae is present just over the ovary and it receives the oocyte at ovulation. What is heterosalpingography? Heterosalpingography, the installation of the viscous iodine through the external ostium of the uterine cervix allow the lumen and the cervical canal, the uterine cavity and the different part of the uterine tubes to be visualized by the X-ray. So here you can see that we can now, because of the injection of the contrast medium, we can see this is like uterus, the triangular one. Normal uterus is triangular on imaging. Then we have the Salpingo tube, and then the contrast is entering the peritoneal cavity as well. Moving forward, we are talking about the branches of internal iliac artery. So these are some branches. Number one is obturator artery, internal iliac artery. So obturator artery, where is obturator? Here we have the obturator artery like this one. Then number two is umbilical artery. So umbilical artery is also a branch. Then we have inferior gluteal artery. Okay, inferior gluteal artery. Point 3, that was about inferior gluteal artery. Where is inferior gluteal artery? It is somewhere, I guess not mentioned in the picture. Then after that we have internal pudendal artery, inferior vesicle in the males and vaginal in the females, middle lateral artery and the uterine artery in the females only. Posterior division include iliac lumbar, lateral sacral and the superior gluteal arteries. Then we have this thing about the, now we are done with the upper limb, lower limb, abdomen, pelvis. Now we are going to talk about the points from 72 to 100. There will be points about head and neck anatomy. So I guess neuro is also included in them. Skull and scalp cranial malformations. What is scaphocephaly? Here you can see scaphocephaly. Premature closure of the sagittal suture. So the sagittal suture, which is like over here, there is premature closure of that, in which the anterior fontanelle is small or absent, result in long, narrow, wedge-shaped cranium. So in the C, you can see oxycephaly, this one. Premature closure of the coronal suture, result in the high tower-like cranium. So there is a high tower-like cranium. Okay. Then we have when premature closure of the coronal or lambdoid suture occurs on one side only, the cranium is twisted asymmetrical condition known as plagiocephaly. So the cranium is twisted like on this side maybe. So that is called as plagiocephaly. So the very first one is scaphocephaly, when sagittal suture is closed prematurely. What is sagittal suture? Let's see that. So sagittal suture. So sagittal suture is this one. Like this is the sagittal suture if it closes prematurely. So first thing, that there will be absence or very small, the presence of very small anterior fontanelle, and secondly there will be elongated anterior posteriorly elongated head that is seen in the scaphocephaly, this picture. Secondly, we are going to talk about the ogyrocephaly. So what is coronal suture? So coronal, this is coronal suture, like these are sutures. So this one is sagittal, like going backwards, and this one is a sagittal suture. If this is closed prematurely, so the head starts moving upwards. So because head has to grow, if this suture is closed, like the suture that was here is closed, so there will be, you know, upward or elongated tower like cranium will be formed. When premature closure of the coronal or the lambdoid suture occurs on one side only, the cranium is twisted and asymmetrical, a condition known as plagiocephaly. Okay, so this is plagiocephaly, like asymmetrical suture, asymmetrical contour or asymmetrical formation of the scalp. Layer of scalp, we'll see that in the next session. Until then, Allah Hafiz and Kema Allah.